Okay, I'm going to go ahead and start. I know that people are going to continue to load on. So welcome again to everyone who is joining us today for our Future of Melanoma Treatment in 2025. As I said before, this has become an annual tradition for AIM at Melanoma, and certainly is one of the most highly anticipated events of our season. We want to thank Dr. Davies and Dr. Talby for their insights on the the things that we have to anticipate in 2025 in terms of research and treatment. And we know that you are going to have questions for the physicians this afternoon at the end of their discussion. If you are joining us on Zoom, then what you will need to do is, if you'll look at the bottom of your screen, you'll see a chat feature. You're welcome to put your general comments in there to let us know where you're joining from. But if you have questions for Dr. Davies and Talby, what you will need to do is to put them into the Q&A feature. You'll see that again right at the bottom of your screen. We also have people that are joining us from Facebook Live and also from YouTube Live. You need to put your comments and questions into the comment section there of the chat feature, and we will take those questions and then we will put them into the Q&A for Dr. Davies and Talby. So once again, thank you for joining us. I'm Ann Garst-Taylor. I am the Director of Community Engagement for AIM at Melanoma. Welcome again, and I will now turn today's symposium over to Dr. Davies and Talby.
All right, thank you so much, Ann, and thank you so much again to AIM at Melanoma for organizing this talk on advances in melanoma. And we really look forward to spending the next hour talking to you about really the progress that's been made, but also what's on the horizon in terms of both new strategies, new approaches, even new clinical trials that we're looking forward to as we head into the new year. So let me just briefly introduce myself and Dr. Talby. So my name is Michael Davis. I am professor and chair of the Department of Melanoma Medical Oncology here at MD Anderson. In addition to seeing patients, I run a research lab. So I'm a physician scientist as well, and have been taking care of melanoma patients for close to 20 years at this point. Hussein.
Yes, thank you, Mike, and I will second your thanks to the AIM at Melanoma, to Ann and Sam Guild for setting this up, and thank you for inviting us. My name is Hussein Talby. I'm a melanoma medical oncologist. I'm also at MD Anderson. I'm deputy chair of the department, which means that Dr. Davis is my boss. I also take care of patients in the clinic and run clinical trials and translational research. And as a testament to what melanoma can do for the rest of cancer, I actually also focus on melanoma brain metastases, and through that have established and co-direct a brain metastases clinic at MD Anderson that sees patients from multiple malignancies as well. So I'm really excited to be here with you this afternoon as well to talk through some of the exciting developments in our field.
Very good. Thank you so much, Hussein. So before we start talking about some of the new trials that we're looking forward to in the coming year, I thought I would give sort of a brief overview about where we stand currently in the treatments for patients with stage 3 and stage 4 melanoma. We're going to spend most of our time focusing on patients with stage 4 melanoma, and that means when melanoma has spread to distant sites in the body, because this is really the space that we've done most of our development of new therapies. But as we'll talk about, many of those therapies have now been used in earlier stages of disease, including stage 3, which means when the melanoma has spread from the place it started to things that are nearby, but can be removed by surgery. We'll talk about some of the changing paradigms there. So again, focusing on patients with stage 4 melanoma, we've been very fortunate to live through a truly revolutionary time. So between 2011 and 2024, the FDA has approved 15 new treatments for patients with stage 4 melanoma. And what's really interesting is that the types of treatments is starting to broaden over time. So let's talk briefly about what are the treatments we use for patients with newly diagnosed stage 4 melanoma. And really sort of the backbone here is the anti-PD-1 antibodies. And so we have 2 different single-agent anti-PD-1 antibodies that have been approved for patients with stage 4 melanoma: pembrolizumab, which is also called Keytruda, and nivolumab, which is called Opdivo. Now, in addition to those single agent treatments, we also have a couple of immunotherapy combinations. The one that's been approved the longest is the combination of nivolumab with ipilimumab, and ipilimumab is called Yervoy. So that combination is sometimes called Opdivo and Yervoy, you'll also hear doctors call it the Ipi-Nivo combination because each of those words is so long. And then Dr. Tabi was really one of the leaders of the trials that led to the approval of our newest immune checkpoint inhibitor combination, nivolumab and relatlimab, called Opdualag. And I will say that although all four of these treatments are approved as first treatments for patients with stage 4 melanoma, both Ipi-Nivo and Opdualag have also shown activity in patients who've progressed on those single agent immune therapies. Staying in the immune therapy realm, we also have an agent called Tvec, which is a medicine that is directly injected into tumors. And so this is something we use in patients who only have superficial lesions, like on the skin or subcutaneous tissue, where we want to have a localized effect without treating the whole body. So now we start getting into some of the newer approvals, and in particular in 2022, we had the approval of a new medicine called tebentafusp, also called Kimtrac. This really stands out in that it's the first immunotherapy that was specifically approved for patients with uveal melanoma. Uveal melanoma is a type of melanoma that starts from the eye and historically has not responded well to those other immune checkpoint inhibitors that I talked about. So this was a huge breakthrough in 2022 to have an effective treatment for patients with uveal melanoma. What we'll also talk about is it represented a new type of immunotherapy, what we call a bispecific antibody. And it started again increasing the number of tools that we have. Most recently, in 2024, we were very excited by the approval of our first cellular immunotherapy for patients with metastatic melanoma, lifileucel, also known as Amtagvi. And this is tumor-infiltrating lymphocyte therapy. What was exciting about this was not only that it was our first cellular therapy that was approved for patients with metastatic melanoma, but it was our first treatment that was specifically approved for patients where our standard immune therapies hadn't worked. So this was really tested in patients who hadn't actually responded to pembrolizumab, nivolumab, Ipi-Nivo, or Opdualag. And this is something that's been shown to achieve durable responses in about 20 to 30% of patients who progressed on those standard treatments. Now, those are therapies that really, again, for cutaneous melanoma can be used for all patients. We also have targeted therapy treatments for patients who have a BRAF mutation. This is present in about 40% of patients with cutaneous melanoma. And for those patients, we do also have the option of targeted therapy combinations, which are pills that are taken either once or twice a day. And in order of how they were approved over time, our first combination was dabrafenib and trametinib, which is also called Tafinlar and Mekinist. We then had vemurafenib and cobimetinib, which is called Zelboraf and Cotellic. And then finally, encorafenib and binimetinib, which is also called Braftovi and Mektovi. We do actually also have one FDA-approved regimen, again, in the frontline setting where we combine immune therapy and targeted therapy together. And that's the combination of vemurafenib, cobimetinib, and atezolizumab, also called Zelboraf, Cotellic, and Tecentriq. So those right now is sort of the existing FDA-approved treatments that we have for patients with stage 4 melanoma. And as you've heard, some of those specifically have been developed initially in the frontline setting, but many of them have also shown activity as a second treatment if your first treatment didn't work. One of the things that is evolving about the melanoma landscape is that we're also seeing many of these treatments now used in earlier stages of disease. And so again, staying on the theme of metastatic melanoma, we also have FDA-approved treatments for patients with stage 3 melanoma, meaning that the melanoma was able to spread from the primary site on the skin to things that are nearby, most commonly lymph nodes. And historically, patients with stage 3 melanoma, we do surgery to remove all the tumors and then try to give treatments to prevent the cancer from coming back. And so in patients with stage 3 melanoma where the cancer's been removed and we want to reduce the risk of the cancer coming back, we have 3 FDA-approved treatments. First is, again, pembrolizumab, also known as Keytruda, given for up to 1 year. Second is nivolumab, again, also known as Opdivo, given for up to 1 year. And then third, for those patients who have a BRAF mutation, we do have one adjuvant targeted therapy approach, which is targeted therapy with dabrafenib and trametinib or Tafinlar and Mekinist for up to 1 year. Now, again, adjuvant therapy has really been the hallmark of melanoma, but what I will say is that although this isn't kind of a formal FDA approval process, what we've also seen really change over the last several years is really the adoption of neoadjuvant therapy for patients with stage 3 melanoma. So, what neoadjuvant therapy is this is an approach where a patient presents with an enlarged lymph node that's involved by cancer, and instead of removing the tumor first and then giving the treatment, we've actually borrowed from the experience in many other cancers, such as breast cancer, to actually find that we can give treatment before we do surgery. And this is something where when we do that treatment, it allows us at the time of surgery to actually see whether this treatment is helping or not, to decide whether that is a good treatment to continue as an adjuvant therapy. We've also learned that seeing that response to that treatment can be very predictive about the risk of whether cancer is going to come back or not. And so in the last couple of years, we've had a couple of really high impact studies that have really demonstrated that giving this treatment before surgery, in addition to after surgery, is actually much more effective than doing surgery first and giving the treatment afterwards. And so this approach of neoadjuvant therapy, I think, has been adopted by most major melanoma centers as really the standard of care for patients who present with stage 3 melanoma that we can see, feel, or measure. And so that's really kind of the landscape of where we are currently for patients with metastatic melanoma. And let me use that then as a transition to talk about what things we think are on the horizon, what are things that are exciting in the coming year. And this is where I get to, again, lean on Hussein, not only because I'm his boss, but because Hussein is genuinely one of the leading medical oncologists and clinical trialists in the melanoma field in the entire world. So Hussein, I think one of the ways we can talk about this is sort of talk about these different categories of treatments that we have, because some of them have been around for a long time, some are newer. And I think it's important for patients to understand what those types of treatments are and what are the settings that we're looking at them. And so, as we talked about, most patients now with metastatic melanoma are getting treated with these immune checkpoint inhibitor antibodies, like Opdivo, like Keytruda, or like the Ipi-Nivo combination. So, in the immune checkpoint inhibitor space, what are sort of the things that you're looking forward to most in the coming year in terms of new strategies or new clinical trials?
Well, thank you, Mike. That was a great introduction, and to your credit, that was covering an entire field in about 6 or 7 minutes. So I know some of the chat is talking about kind of having a transcript of this, but we hope to actually go a little deeper on each of these agents to kind of give you a better sense of that. But that was the overview. I mean, I really think that in melanoma, we need to take account of the fact that, all of these immunotherapies actually start in melanoma. Most of the original research started in metastatic melanoma patients, starting with the anti-CTLA-4 antibody ipilimumab, and then moving on to single agent PD-1, and as you mentioned, the combinations. And so, what's really exciting for us and for our patients is the fact that these therapies do affect long-term durable responses. And what we've learned, even just in the last year, that we now have 10-year data from the combination of ipilimumab and nivolumab that shows that, we can really give long-term durable remissions for over 50% of our patients. And that's really just really heartwarming and puts us in a place where we could really offer kind of dramatic outcomes for some of our patients. We also take into account the fact that, those are cancer therapies, and cancer therapies unfortunately come at a cost, and in some cases, the cost of toxicity. So we know that the combination of ipilimumab and nivolumab, helps over 50% of patients, but does cause immune-related adverse events in about half of the patients as well. We have, as a field, and most medical oncologists now have a good way of really an experience in how to manage those effectively. So we do really well for our patients, even if they develop toxicity. But the idea of trying to develop newer agents that can give us the benefit of immunotherapy, activating that immune system without necessarily causing as much toxicity, has been what we've been trying to do for 15 years. And I think newer drugs like the anti-LAG-3 antibody, relatlimab in combination with nivolumab, or the Opdualag combination you mentioned, has really given us kind of the first foray into that. Now we have a combination that has really impressive activity, about similar to Ipi and Nivo, maybe slightly less potent, but the toxicity benefit is so much less. So we get toxicity only in about 22% of patients compared to 50% of patients or so. Now, you mentioned something really critical, and I think it's important for all of the patients to hear, is that most of those clinical trials have been ran in the first-line setting, and we actually don't have comparative trials of, say, the combination of Opdualag to Ipi/Nivo as a combination. They haven't been compared head-to-head. We only have the trial of one of them against nivolumab and one of them against ipilimumab, actually. And so at the first level, I think in terms of decision-making in the clinic, we only have one really great trial that compared targeted therapy to immunotherapy and very clearly told us that for BRAF, for patients that have a BRAF mutation, immunotherapy first makes the most sense. And that's been a long discussion in the field. But we still don't know right now which immunotherapies to start with. Do we start with Ipi/Nivo or do we start with Opdualag or Opdivo or Opdualag? And again, that's currently a clinical decision. And then if our patients progress after one of the combinations, then we could use potentially the other combination. Or if those patients are have BRAF mutated melanoma, they can go to BRAF and MEK inhibitors. That's how we practice right now. But you asked me, Mike, what am I looking forward to in the next year? I think a couple of things. One is we're actually starting to learn about the role of drugs like Opdualag in different settings, right? Like we're trying to see if it works in melanoma brain metastases, which we know that Ipi/Nivo does work for melanoma brain metastases really, really well, but again, with the risk of toxicity. And we're trying to prove that this new combination that is safer can potentially be used in the same patient population. So there's kind of that is happening in the field. What's the role of Opdualag in other settings? Brain metastases, we're looking at the adjuvant setting and whether we can treat patients to prevent recurrence for stage 3. But also, two additional things. One is we're looking at potentially combining all 3 checkpoints. So now we have 3 different checkpoints that target different things on different T cells, potentially at different times of evolution of the T cell. And there could be benefit to actually using them all together. There's been a very early trial which used all 3 drugs together and seemed to give outcomes that are exciting. The PFS looks, better than what we have with either doublet. It was a relatively small study with about 46 patients, and it's called Relativity-048. I think we're really excited about that because it opened up kind of a new avenue of research. As you know, Mike, we are working here at MD Anderson on actually finding the right dose of these drugs to combine together so that we can maximize the outcome while we manage the toxicity to the best that we can. But in that space, we also have other checkpoints that are being considered. So today we're discussing the future, so I'm not going to rely only on the drugs that we have in hand, but there are different ways to target the checkpoints right now. Some of them are actually using the same antibody to target 2 different checkpoints, and those are called bispecific antibodies that are currently in phase 1 trials. We're hoping that by being able to do these bispecifics, we can really target more specific cell populations and be kind of, again, maximize this risk benefit between the 2. So that's an exciting aspect of checkpoint inhibition. And then there are other checkpoints that are still being considered. So for instance, TIGIT is a checkpoint that has been initially interesting, and a phase 3 trial in the adjuvant setting was disappointing. But I do think a drug, that checkpoint actually has a life to it. It just needs to probably be combined with the right, kind of drugs to make an effect. So we are pursuing other checkpoints in this space as well. So I'm going to stop here for a second. This is all in the first line setting. And just if you have any comments, Mike, and then we can talk about second line trials as well.
Yeah, no, thanks, Hussein. You covered a lot of ground there. And so just again, to sort of briefly summarize this for people, when we talk with patients about should we do the Ipi/Nivo combination, should we do Opdualag, one of the things that I think is coming is the idea of actually pulling the three medicines together. And so I think this is one of the things that we're going to start to see in the future is going from single agents to doublets now to using three different medicines together. I think one of the other things that we've seen some excitement about is that, again, the approval of Opdualag was the first LAG-3 antibody to be approved in any cancer, and in melanoma, we are seeing other LAG-3 antibodies that have looked very promising in clinical trials. And so there's going to be clinical trials that are ongoing in multiple different settings with a new LAG-3 antibody called fianlimab in combination with cemiplimab. And so when you sort of hear about it, it's kind of a target that's been validated already that's going to be explored in multiple different clinical trials this year. Moving on then, as I mentioned, one of the exciting things about the past year was our first approval of a cellular therapy with lifileucel or Amtagvi. And so, it's one of the things we think that this is sort of the tip of the iceberg in terms of sort of potential opportunities for cellular therapy. So why don't we spend a few minutes talking about sort of, again, what we know about lifileucel and what are some of the clinical trials that are coming down the pike that we're excited about with cellular therapy options for patients with metastatic melanoma.
Yeah, definitely. It was amazing to see this treatment modality that's been around for a couple of decades finally make it to FDA approval and become more widely available for our patients. And, a couple of things that I think this particular approval leads to. One is it's one of the first, as you mentioned, and I was just complaining about how all of our trials are in the first line setting. At least this was a second line PD-1 refractory population that's been included on the trial. So it was great to see that the second line patients now have an FDA approved option. The second component that may help drug development in the future is the approval was based on a single arm trial to a degree. It wasn't a randomized study, so that opens the door for potentially kind of faster approval in that space. And we hope that we'll be able to bring more agents in that way. Now, the TIL therapy itself, as you know, Mike, has been used in the same fashion that it was approved for almost 3 decades. And the idea of that is simply that the lymphocytes that are sitting inside the melanoma tumor are lymphocytes that have already gone through multiple phases to be able to recognize the tumor, to proliferate and to circulate and get into the tumor and start attacking it. So we think that those cells have a lot to offer, but while they're sitting in that tumor, they're really immune suppressed by the suppressive environment of the tumor itself. So by taking them out surgically, as it stands for the Iovance treatment, and isolating the lymphocytes from this kind of toxic environment for them to a degree, and growing them in the lab, I tell my patients we kind of pamper them and give them everything they love so that they can actually be happy and grow and eventually multiply, and then we can give them back in the billions to our patients. Then the patients are treated with a low-dose chemotherapy to prepare them for the infusion with the lymphocytes, and then the TIL therapy is given, followed by 3 days of interleukin-2. So what's really important about this, it is a process, and it is not kind of, the logistics of it are somewhat complicated, but the amazing part is that about a third of the patients actually have good responses to this. Some of those responses end up being really durable. So it's offering our patients a new treatment option that was not previously widely available. So that's kind of at a basic level. What's really exciting is that it actually opens a whole new field of investigation, right? So the current TIL approach takes the lymphocytes that are sitting in the tumor, and those are the exact lymphocytes that patients get back. But now we have the ability to take those lymphocytes and actually modify them and try to make them even more effective. So that's where a lot of the current clinical trials in this space are focusing on, which pieces of those T cells you can modify to make them, say, less immune suppressed or more capable of being able to be effective. There's even approaches to actually sort those T cells and choose the ones that are most likely to be effective. So this is some of the trials that are being considered. So I'll mention maybe a couple just to be more specific about this. Like at MD Anderson, we're running a trial with Dr. Amaria, who's our leader of the TIL program, where with a company called Obsidian, where the T cells are modified in a way that allow them to be almost auto-activated. They won't be needing the interleukin-2 component, which is actually a really difficult part for patients and sometimes toxic part. So these cells are modified in a way that you could activate something very similar to interleukin-2 on their surface called interleukin-15 with actually the use of a pill that allows those T cells to potentially proliferate and continue to work in the patients after they get infused. So that's a really exciting avenue, and it's a study that Dr. Amaria presented a few patients at past ASCO showing some interesting activity. There are other T cells that are being kind of designed to have PD-L1 being kind of deactivated as well, so that they cannot be suppressed by the tumor microenvironment. So some of those trials, I think, are capable of really transforming the field. So we're kind of really grateful that we have what at MD Anderson we call vanilla TIL, because that is kind of like the most basic, that is the Iovance TIL. It's really exciting to be able to modify those T cells and learn how we can make them even more effective.
So just to summarize, we were really excited about the approval of lifileucel last year. I will say that, again, lifileucel was approved specifically for patients who had already received our standard frontline immune therapies that hadn't worked and then are receiving this treatment. There is a trial that is actually asking whether or not lifileucel should be used in the frontline setting. It is a study that's being conducted at multiple different sites around the world. It's an interesting question, somewhat controversial because of how good the outcomes are with many of our treatments that are very safe and easy to administer. But that is one of the trials that's going on. As Dr. Tabi mentioned, we're really excited about the idea of new strategies which are taking TIL and trying to make them work better, and particularly trying to make them safer and easier to use, because high-dose IL-2 is something that can really only be done at large centers that have a lot of experience with that. But staying in the cell therapy, I think one of the other sort of breakthroughs has been actually exciting data with a different type of cell therapy called TCR T cell therapy that's looked very promising and is also going to be used in several trials this year. Hussein, we want to talk a little bit about maybe the PRAME TCRT.
Yeah, so that's kind of another aspect that is really interesting and exciting in terms of new ways you can use those T cells. So essentially the way this works is, instead of actually going into the tumor, identifying the lymphocytes that are sitting there, you could actually isolate lymphocytes from circulating in the blood of patients, take those lymphocytes and actually modify them so that you could add a T cell receptor on top of them that is specific to the antigen that you're interested in. And by doing that, basically you're kind of manufacturing T cells that are capable of going and being able to kill any cell that expresses that antigen. And so that's kind of the idea of TCR T cells. Melanoma is actually interesting in that it has some expression of certain antigens that are almost universal. And I actually see that Graham here is on the call and asking us question, and he had led some of the trials that were focusing on PRAME and MAGE-3 in the past. But MAGE-3, PRAME are some of the antigens that are expressed almost on every melanoma cell. So it actually makes a lot of sense to put T cells that are specific to that antigen that could go and kill the tumors that express them. So the early trials from some of the companies like Immatics have actually shown really impressive results. There's also one bispecific that's more of a T cell engager with PRAME as well, that's called brenetafusp. It's also kind of a similar idea, slightly different, and I can go over that in a minute. But the exciting part is now the company is interested enough, based on these results and the investigators, that we're going to be running a randomized study in the second-line setting using these agents. And again, we really hope that will open up a new avenue for our patients. So just briefly to mention brenetafusp. I'm sorry, Mike, did you want to?
No, and I was just going to say, just one of the questions that popped up, I think, is relevant, because often when we talk about these treatments, we're really referring to data that has been generated in patients with cutaneous melanomas, where the activity has been seen the most. But there was a question about, will these work in mucosal melanoma? And I will say that, we actually have now a small cohort of mucosal melanoma patients treated with lifileucel that showed a similar response rate to what we've seen in cutaneous melanoma patients. And the target that we're talking about with the TCRT and the bispecific frame is something that's really expressed at very high levels in all subtypes of melanoma, as far as we can tell, cutaneous, mucosal, and uveal. And the clinical trials with these TCR-T cells targeting frame have definitely shown activity in cutaneous melanoma, in uveal melanoma, and mucosal melanoma. But certainly recognizing mucosal melanoma is a challenge, particularly because mucosal melanoma doesn't seem to respond as well to those standard checkpoint inhibitors that we talked about at the beginning. So sorry to interrupt, Hussein. I think you were starting to talk a little bit more about the bispecific antibodies.
Yeah, I mean, the idea is the target is very relevant, as you mentioned. PRAME is one of the, we also think about, like, not to get too specifics, but you think about not just whether the antigen is expressed or not. You also want to think about the density of expression, and PRAME is very highly densely expressed, so it may be an even more exciting target than GP100. So you heard from Dr. Davis early on about the tebentafusp, which is a drug that's been approved for uveal melanoma. And what that drug does is it's a bispecific. On the one side, it has a receptor for the T cells, and on the other side, it has the antibody for the antigen, in this case, GP100 for tebentafusp. So what that allows you to do is it allows you to, like, literally bring into close proximity a T cell that expresses CD3, so that's how you know. And then on the other hand, you have the tumor cell on the other side that's attached to the antigen. And so that way you can start an immune response to that cell using this bispecific T cell engager approach. And again, tebentafusp worked in uveal melanoma very well. It should be noted that GP100, which is expressed on uveal melanoma cells, is also expressed on cutaneous melanoma cells. And so there have been some trials using tebentafusp in cutaneous melanoma as well. They've been interesting. I wouldn't say that they've been wildly successful, but there's some activity with that approach. But now using PRAME, again, because PRAME is a much more densely expressed antigen, it is possible that that same approach using PRAME may actually be more effective. And so the early data from brenetafusp, which is the same exact idea of a T cell engager, CD3 on one side and the antigen to PRAME on the other side, the early data looked promising enough, again, that we expect this to be moving into randomized trials very soon. In fact, it is already in a randomized phase 3 trial. I apologize. It's in a randomized phase 3 trial in combination with single agent PD-1 compared to single agent PD-1 versus nivo-rela in the first line setting.
That's great. Well, listen, I know it's hard to really cover everything, but I do want to make sure that we leave some time to be able to answer some questions. So I'm going to talk briefly about, one of the things that we also sort of recognize is that there are different subtypes of melanoma, different sites of disease, and often it's actually been challenging for people to find clinical trials in some of these scenarios. And so just want to talk about a couple of those scenarios and what some of the trials are that are actually available for people, because people often think, I don't have any trials available to me. We've talked a bit about uveal melanoma, again, as a disease that didn't respond as well to the checkpoint inhibitors. We talked about tebentafusp being sort of, again, a real breakthrough. Kimmtrak being approved as a therapy there for patients with stage 4 metastatic uveal melanoma. As we've seen with cutaneous melanoma, Kimmtrak is now being tested in the adjuvant setting. It's actually being explored in patients who have been rendered free of disease to see if that can prevent the cancer from coming back. And then I think one of the really exciting sort of trials we're looking forward to seeing the results of is a new targeted therapy approach for uveal melanoma. And this is driven by the fact that uveal melanoma very commonly has mutations in genes called GNAQ or GNA11, sort of the same way in cutaneous melanoma we see BRAF and NRAS mutations, but it turns out these GNAQ and GNA11 mutations need very different treatments. And so there's a combination targeted therapy. I actually still have trouble pronouncing these, but there's a medicine called darovasertib, which is a PKC inhibitor combined with crizotinib that's shown very promising results in non-randomized trials. That's now in a randomized study. And interestingly, there's even been trials for patients who've been diagnosed with uveal melanoma in the eye, asking if you give this treatment up front, could you actually rescue vision? And so this is going to be, again, a new approach for patients with uveal melanoma. I will say something that Dr. Tabi and I share a passion for is also patients who develop metastases to the central nervous system, including the brain and the spinal cord, or the lining of the brain, which is called leptomeningeal disease. Historically, we've known that melanoma has a very high risk of cancer spreading to these sites. And unfortunately, for decades, patients who had CNS metastases were excluded from clinical trials. And one of the things that we've really tried to focus on as investigators, as a community, and working with the FDA is trying to actually open up clinical trial options for patients with CNS involvement. So Hussein, maybe we can sort of tag team here. Maybe, again, particularly with your role, do you want to talk a little bit about some of the clinical investigations for patients with brain metastases?
Yeah, thank you, Mike. I mean, I think I mentioned this in the early introduction that, melanoma is a place where, first of all, brain metastases happen a lot. It's one of the most common solid tumors to go to the brain. And at the time of diagnosis of metastatic disease, I think it's very important for patients to know that it is very important to check the brain at the time of diagnosis of metastatic disease, even without any symptoms, to look for any potential brain metastases. And unfortunately, most of the studies show that if you check at that time, there's about 30 to 40% of patients that may already have brain metastases. And traditionally, drug development had been performed in a way where clinical trials automatically excluded patients that had brain metastases. Basically, the reflex was to send those patients to the radiation oncologist or the neurosurgeon saying, please handle this. And then when the brain is under control, then we can treat our patients with systemic therapy. And I think melanoma is the field where we proved that that is not necessary, that you may be able to treat patients with the same agents you use for extracranial disease for metastatic melanoma. They may have activity in the brain. So, Mike, maybe I'll turn it over to you to talk about how you showed the value of targeted therapy in brain metastases, and then I'll talk briefly about what the role of immunotherapy for brain metastases has been.
I think the idea is that we've first showed that, again, in clinical trials, targeted therapy for patients with a BRAF mutation was very safe to use in patients with brain metastases. There were no new or unusual side effects. And the treatments had a very good chance of getting the disease under control, even in patients who had very advanced disease requiring steroids. But unfortunately, what we saw was that the treatments didn't work as long as what we had experienced in patients with extracranial disease. And so, although targeted therapies can help, we probably don't see them as sort of the long-term option for patients with brain metastases, which is where, again, the immunotherapy trials have been so striking, including the trials that you led with ipilimumab and nivolumab, and hopefully, as you mentioned, the trial you're leading now with Opdualag.
Yeah, so that's the idea that our drugs that work outside the brain have activity in the brain, but you really need to run the clinical trial in that population to learn how they work and what are the benefits and the limitations. So we learned from targeted therapy that yes, you can have a relatively quick response. Within potentially days, you could shrink down a brain mass with targeted therapy if the patient has a BRAF mutation in their tumor. But we know that once you do that, you will have to already be thinking about what your next step is going to be because of that durability issue. With immunotherapy, the traditional thought was that if you treat with immunotherapy, you induce inflammation, you want the immune system to come in, so it may end up being not safe enough because you're causing swelling in the brain. And we actually ended up showing that that is not the case, that the response actually happens faster than you can induce inflammation. You don't cause a lot of edema in the brain with immunotherapy. And with combination specifically with ipilimumab and nivolumab, just the same rate of about 50-55% of patients that respond outside the brain, we see about the same exact response in the brain. And in this case, it is durable. It is once you teach those T cells how to get into the brain and into the melanoma, and they know how to control it, you get these long-term durable responses. So for that trial, Checkmate 204, we had been following those patients for years. At 3 years, almost 90% of the responses were ongoing, which is really great. The flip side to that is, those patients could not be using steroids. If they were using steroids to treat the swelling from brain metastases, the symptoms that those patients were having, then immunotherapy did not work, or not as well, at least. It was only effective in about 20%. So that, on the one hand, that's why I was saying it's important to run these trials, because we learn what we need to do. One is we know that we can treat asymptomatic patients with combination immunotherapy before we pull the trigger on radiation. Half of them will do really well. The other half may need radiation. And two, we know that if someone requires steroids, then maybe you should do other things to get them off those steroids so that they could be eventually responsive to immunotherapy. And as I mentioned earlier, Ipi/Nivo has been kind of in our hands for over a decade. We've learned a lot from it, including for brain metastases. But now that we have newer drugs like Opdualag, again, new combination, we don't know exactly what its efficacy in the brain is, so we have to run the trial that specifically takes that population into account and really be able to learn, its benefits and whether we need to do things slightly differently. So I can tell you our study is planned to have about 30 patients on it. We're about halfway through, and we're hoping to continue learning about the role of that combination in brain metastases.
So as we talked about at the beginning, the new types of therapies that are being used, one of the questions that's come up is whether the cell therapies can work in patients with brain metastases. And just to sort of give you a quick update on that, Dr. Alison Bedoff-Warner reported at our SMR meeting a few months ago, the first cohort of patients treated with lifileucel for patients with brain metastases, which they modified the regimen a bit to lessen the risk of thrombocytopenia and bleeding, but definitely showed it was feasible to use TIL therapy in patients with brain metastases. And this was given by IV, and showed that it absolutely could work. And I'd also like to highlight Dr. Carrie Kendra at Ohio State, who has another cell therapy trial specifically for patients with brain metastases with NK cell therapy. And then finally, kind of our final frontier for melanoma is when melanoma gets to the lining of the brain, which is called leptomeningeal disease, or LMD. And this is a place where we have a long-standing experience with MD Anderson of actually giving medicines directly into the spinal fluid. We did a first-in-human study led by our own Dr. Glitza that showed the safety of doing this with nivolumab or Opdivo, and the fact that even in patients who had progressed on IV Opdivo treatment, that giving this intrathecally could be safe and effective. She now has a trial doing this with a different immunotherapy with intrathecal Opdualag, and Adrian Boir up at Memorial Sloan Kettering has a trial of another intrathecal medicine called deferoxamine. And I think the overall kind of theme of all of these trials, though, is that whereas historically it's been so hard to find a clinical trial if you have leptomeningeal disease, even patients with leptomeningeal disease do have some trial options now. With that, I think this would be sort of a good time for us to transition to answering some of the questions. And there's a couple of themes that I think are worth talking about. There's several people who have kind of talked about how durable can the good effects of immunotherapy be. People talking about being on treatment for a period of time, but now being off of that treatment for several years and wondering how long it can work. Am I going to need to be treated again, or can this be enough? And this is one of the remarkable things about immunotherapy. Have to remember that when we give the immunotherapy like Opdivo, Keytruda, Ipi/Nivo, Opdualag, the medicine doesn't attack the tumors. What the medicine does is tries to actually activate your own immune system to attack the cancer. And what we've learned over time is that if your immune system can learn how to attack the cancer, it can probably keep doing that even without us giving infusions. I have to say there's always a question in the field about should we be giving longer treatments, but I will say there's more and more data about immunotherapy asking, are we giving treatment too long? Could we actually be giving treatment for shorter periods of time? Because as Hussein was talking about the Checkmate 067 trial, where we just saw the 10-year outcomes, In that clinical trial, patients who developed severe toxicity from their treatment were not allowed to get any subsequent treatments. And again, the ipi-nivo combination is very powerful with a 50 to 60% response rate, but also about a 50% risk of serious toxicities. And what we saw is that the patients who were treated with ipi-nivo in that trial, most of whom who responded only received treatment for 3 months or less. Most of those responders were still alive and well 10 years later without any additional treatment. And so it really highlights the fact that, we actually don't have a great answer yet on how long you need to be treated with immunotherapy to get those long-term benefits. Now, the flip side to that, which multiple people have sort of raised questions about in the chat, is what about the durability of those side effects? And that is the other edge of the sword. The great thing about immunotherapy is that the therapeutic effects can be very durable, but the downside is the fact that toxicities can be very durable as well. What we're seeing at many centers, and this is not just Anderson, but many other centers, Mass General, Sloan Kettering, are really now concentrated efforts and experts really focused on how we can treat or prevent the side effects of immunotherapy. We recognize that, again, there's a subset of patients who can get very severe or very long-lasting toxicities. And I have to say that this is something where we really work very closely with specialists in dermatology, in gastroenterology, who really, again, are potentially have a lot of expertise and resources to bring to the table from other autoimmune diseases. And so, as many people sort of ask about the long-term toxicities, we absolutely recognize that that is a potential with these treatments and something that many people are working on, but a lot of times hard to come up with an answer to. So that's, again, just some of the questions that I've sort of seen here. We've mentioned about mucosal melanoma and the fact that many of the therapies, particularly these cell therapies, seem to have a lot of potential for mucosal melanoma. And many of these trials are including those patients. There are also now an increasing number of trials, fortunately, that are being opened specifically for patients with mucosal melanoma, recognizing sort of, again, the fact that mucosal melanoma hasn't had the same high response rates with the checkpoint inhibitors that we've seen with cutaneous melanoma. Let me see. I don't know, Hussein, if you've been looking through the questions, if you saw any that you'd like to answer.
Yeah, I have a couple. First, I'd like to kind of highlight again what you mentioned about the durability of the responses. I mean, the interesting thing is some of the data from the long term, even from single agent PD-1, kind of say that partial response, complete response patients, have excellent survival even at 10 years down the line. A couple of questions that I thought would be really interesting, maybe for the entire group to hear about, is about circulating tumor DNA. I think that's a really good question and a field that is evolving. I can tell you in other cancers, it's gotten to be really critical for management, like for patients with colorectal cancer and other cancers. In melanoma, I think the data is slowly accumulating towards potential use of these approaches. In the adjuvant setting, I can tell you one of the challenges is that circulating tumor DNA is positive in a very small number of patients, so about 16%. So if those are positive, we kind of have a sense of what happens and how we can help those patients. And if you treat and the circulating tumor DNA goes away, then that may actually be really a much better outcome. But the other 84% that are negative, we actually don't know. And so that's kind of one of the challenges with circulating tumor DNA, at least in the adjuvant setting. In the metastatic setting, we're actually in the process of learning how much can it drive therapy. So far, all I've seen in the data is that it does kind of correlate with tumor response. So it is maybe a bit more sensitive measure of whether the tumor is responding or not, but it hasn't risen to a level that I personally use to make decisions for my patients. I think it's a really exciting research avenue, and if those assays become a bit more sensitive, and if the data continues to accumulate in the same direction, perhaps in the next, I would say, 3 to 5 years, we may be using those for treatment decisions, but not at this moment.
Just saying, there's a question here that's a topic that, to be perfectly honest, I thought we might see some questions about, which is the idea of the vaccines. And, if you could talk a little bit about what is sort of, again, what we've seen with the personalized vaccines recently, what's kind of the status of those investigations and what you think about that as a potential new tool in the toolbox for us moving forward?
Yeah, I mean, this is really interesting. And I would say the technology to make vaccines more effective, more available, I think that that's been really probably, it started in melanoma. I don't know if people know that while we use messenger RNA vaccines to, kind of transform the world with, managing COVID, the truth is, some of the early data in messenger RNA vaccines were actually in melanoma before it was shifted towards COVID, which I think is always an interesting tidbit for people to hear. But then, the idea of being able to use that technology allows for it's a bit more effective than, say, peptide vaccines. In melanoma, we've used vaccines for decades. And the idea is that messenger RNA may allow a much more directed, specific, and effective immune response. So far, let's just be clear that the place where this seems to be most relevant remains in the adjuvant setting. There's a lot of work to discuss whether we'll be able to use that technology in the metastatic setting, but I do want patients to be aware that there are some logistics and mechanics to getting the messenger RNA vaccine. It involves getting the tumor tissue, sequencing it, and then generating the vaccine, which could take weeks. The time seems to start, hopefully as the technology evolves, maybe it'll become shorter and shorter, but it is in the 6 to 9 weeks range, which is why for adjuvant therapy, that works really great because you take the tumor out, the patient is free of disease, they can get started on checkpoint inhibitors, then the vaccine is being developed, and as soon as it's available, then you add it to the checkpoint inhibitor. And that's what the one trial that was performed, the randomized study, had done. And what that did is basically about 8 to 9 months later, you saw that those patients that got the vaccine had much less recurrence than patients that didn't. So that was really exciting. And now we are waiting for the results for a phase 3 trial that used the same approach across almost 1,500 patients. So I think if that trial comes out to be positive, then we will have that technology available as a standard treatment for patients in the adjuvant setting. Whether this will be useful in the neoadjuvant setting or in the metastatic setting, I think that's going to be a little trickier just because of those logistics that I mentioned, right? So patients in the adjuvant setting can wait several weeks to be treated. In the metastatic setting, we kind of under a little bit more of a pressure of time to get started on treatment. So there may be some logistic challenges there, but I do think it's a technology that may be useful in multiple ways. And it is quite exciting that it seems to not cause additional toxicity, but helps the immune system, recognize the tumor more.
I see a couple of questions around sort of mutations and targeted therapies. So maybe I can talk a little bit about some of the investigations that are going on there. And so just briefly, again, if we talk about cutaneous melanoma, the most common mutations we see are the BRAF V600 mutations, and about 40 to 45%. About 20% of patients have mutations in the gene called NRAS, and these are mutually exclusive with BRAF. A patient will have one or the other, but not both. NRAS is something where we've actually seen some clinical activity in clinical trials with MEK inhibitors. And in our NCCN guidelines, treatment with the MEK inhibitor binimetinib or Mektovi is actually in our guidelines as a treatment there, but it's not actually technically an FDA-approved treatment. There are sort of clinical trials that are going on now, actually combining MEK inhibitors with pan-RAF inhibitors, even phase 3 studies. And so patients with NRAS mutations do have clinical trial options that are out there. And to be perfectly honest, what we're really hoping for is there's been a lot of progress in other cancers that have mutations in other types of RAS genes that have been quite exciting, that we hope will eventually lead to exciting new drugs and trials in patients with cutaneous melanoma as well. The challenge we have for NRAS is that NRAS is not usually the form of RAS that's mutated in colon cancer, pancreatic cancer, or lung cancer. Those are usually KRAS or HRAS, and our mutations happen in a different place. Now, there's also been a couple of questions about mutations in BRAF, but not at the V600 site. Those, again, do remain a challenge. Those tumors with those mutations can respond to MEK inhibitors or potentially pan-RAF inhibitors. There are companies that are developing agents specifically for the non-V600 mutations. I will say one of the things that complicates that is while the BRAF V600 mutations and NRAS mutations are mutually exclusive, because they activate the MAP kinase pathway so potently, these other mutations we see in BRAF are often co-occurring with other mutations in the pathway. It gets kind of complicated when you have multiple mutations in the same pathway. So unfortunately, not as many trials as we have for BRAF V600 or NRAS, but trials that are targeting the MAP kinase pathway are often good options if your tumor has one of those non-V600 BRAF mutations.
Great. I'm gonna just bring up two quick things. I know we're running out of time, but just to kind of tell people about some of the exciting stuff. So there was a question about oncolytic viruses, and I think that is we have really TVEC has been the only oncolytic virus that's been FDA approved, and it's a useful agent, but it has its challenges, and it's not. I wouldn't say it's a particularly potent agent. We kind of use it in very specific situations. Where patients have accessible lesions that we could, inject the oncolytic virus in. But the dynamics of response with TVEC, in my experience, takes about 3 to 6 months to take full effect. So it's a specific population that we can do this in. But there are newer oncolytic viruses, like the Replimune oncolytic viruses, that seem to be, kind of more effective, more potent, at least in the data that has been done so far in combination with PD-1. RP1 is one of this oncolytic viruses that is being trialed in a phase 3 trial. What's really exciting to me about those things is that the oncolytic viruses now can be modified to add more things to them beyond just GM-CSF and its oncolytic component, where you could start modulating even the checkpoints. So even Replimune that has RP1 also has a couple of other agents called RP2 and RP3, and kind of in that setting, I think you may be able to innovate with more kind of evolved oncolytic viruses. So that's what's exciting to me about that part. And then one other thing we kind of really did not broach at all today, but I think it's something that patients need to start being sensitive to, is something called ADCs, or antibody drug conjugates. Those are kind of really the craze in most other cancers. Like in breast cancer, they're making a really significant impact. They're improving survival in patients with breast cancer. And some of those ADCs, it's basically on the one side, it's an antibody. On the other side, it actually has chemotherapy drugs attached to it that are capable of really killing those cells that the antibody is targeted to. There may be some antigens that will be relevant for melanoma, like one of those that are coming along that Dr. Davis is involved in as well are called HER3 ADCs. And HER3 is, again, something that is expressed on melanoma cells. So just speaking about some of the, kind of early results from things that could be relevant, I think oncolytic viruses and ADCs are definitely agents that may be relevant in the short term.
So as we come up on the end of our hour, we were talking again amongst ourselves and with some of the members of the AIM team about we have a really good problem and that there's so much to talk about. I can tell you when I got started in this field, we had so few tools to work with and so little progress. And so I really do apologize that we couldn't cover more, but I think, some of the take-home messages is that the different types of treatments that we have for melanoma is really expanding. And so again, we've really sort of got a strong foundation to build upon with the checkpoint inhibitor antibodies, but we're moving into an era now where we actually are going to have multiple different types of treatment for patients with melanoma. We'll have the checkpoint inhibitor antibodies, we'll have cellular therapies, we'll have bispecific antibodies, hopefully we'll have things like genetically modified TIL and certainly targeted therapies as well, and intratumoral therapies. Hopefully the list continues to grow. And the clinical trials are going to be looking both in the frontline setting and in patients who didn't respond to those initial treatments. There's always going to be limitations to clinical trials based on previous toxicities. But actually, for those of you who've asked, patients who've had severe toxicities with the checkpoint inhibitors, we generally think it's safe to use things like the cellular therapies because they work so differently. So having had bad side effects with one type of treatment doesn't necessarily close the door to all of these clinical trials. And again, hopefully many of you are out there who are never going to need any of these treatments that we talked about, but it's one of those things where there remain many interesting and exciting trials. And again, we have so many patients who are alive and well today because of the people who participated in trials in the past. We really appreciate people who are willing to participate in these studies, and certainly hope that by participating in these studies, you get access early on to what's going to be the standard of care in the future. So it's a complicated environment, but again, I will say having to pick through a lot of different options is a lot better than the challenge when we had so few options. And I have to say, the other thing that I really have come to appreciate, and or really have always appreciated, is really how engaged and informed the melanoma community is. You know, hearing how many people signed up for this today, there's really been some great questions. I apologize again, we couldn't get to all of them. And I think that, again, AIM is going to have a way to provide more information through its social media outlets to address some of those. But it's really, again, a pleasure to be able to talk to all of you today about some of the progress we've made and some of the things we find most interesting. Hussein, anything you'd like to close with?
I just thank you, Mike, for kind of preparing this and providing the overview and for inviting me for this. Thanks for AIM for being such a phenomenal advocate for patients across the board, and I think it's a really great organization. I hope, if anything, for all of our patients on this call, first to know that we are ready with the drugs that are at our disposal. We can help so many patients, and that is, as Mike said, I started treating melanoma patients in 2005, and so it is absolutely heartwarming to be able to do this for our patients. But I hope you have also gotten the sense of how excited we are as investigators because we have so many venues that we could go to improve the outcome of our patients. And I think melanoma does stand to be one of the cancers that informs the entire field. And I think it's been really great that we make advances that can help all cancer patients, not only melanoma patients. So I am grateful to be in this field. I'm grateful to be taking care of patients with melanoma and to be able to kind of continue to push the envelope. So thank you for the opportunity and for all of you who signed in. And I am really sorry. It's a lot of questions, and I wish we could answer almost every one of them. Every one of them is valid, and hope to be able to work with AIM on helping answer some of those as well.
It's good. Anne or Sam, do you have any sort of closing messages just for our audience or on behalf of AIM?
We can't close without thanking you for this absolutely inspirational, encouraging conversation that you had today. It was a conversation filled with hope, and I know everyone feels that, and I know you can see in the chat all the praise that you are getting from those who had the time to visit us today. And I just want to assure everyone, many people have asked if they can view this again. There was so much wonderful information, they couldn't possibly absorb it all. You can go to our YouTube live page, and as soon as this symposium is over, you're welcome to view it again. You're welcome to share it. If we have any resources at AIM at Melanoma that we can share with you in terms of patient information, our Ask a Medical Expert service, those kinds of things, please feel free to reach out to us. We are here to serve you. And with that, I just want to thank MD Anderson. I want to thank our viewers and wish everyone a pleasant evening. Good night.
Take care, everyone. Thank you.